Hello, we're here at the Miramar Centers for CCMS, and my name is Mario Espino. I'm the founder and the chairman of the board for the company, and I just want to tell you how excited we are today about our guest. Someone that I've known for a short while, but you know, when you find that diamond in the rough, you want to hang on to him, and his name is Cesar Rodriguez. Dr. Rodriguez, thank you for not only being here, but also being the chief medical officer for the company, responsible for the clinical side of the company. I appreciate you so much being here, and I think that the conversation today is going to be perfect for those people that watch this podcast, because it's going to be full of information that they can use, or they know someone that can use, so that they can have a fruitful quality of life and remain in their home and age and place in their home. So once again, thank you, Cesar, for being here. Thank you for being part of the organization. I know, Cesar, just to get started, I know some months back you came to me and you told me that we needed to retrain the nurses in the field a little bit. And I said, well, you know, why? Why do we need to retrain the nurses in the field? And he says, Mario, because the nurses in the field are capturing data on the diseases that nurses would capture, but it's not the necessary information that the doctor needs in order to make a good evaluation or decision on that patient, because they don't have that data. And I said, okay, well, great, no problem. Let's go ahead and let's start developing. And we took some time and we put together the 7 most or 8 most common diagnoses that were out there and how we can handle them. Tell us a little bit about that.
So, I mean, first of all, yes, thank you, Mr. Mario, to have me here. As you said, I'm Cesar Rodriguez. Been in the company for about 3 months already. Been having as a chief medical officer, and the idea came out when we decided to meet one day, and we see the plan that the company, what you was doing. And I've been doing hospital medicine for more than almost 20 years in Miami, in any different facility, and I know how is the necessity that we have it to get a transition care in between the hospital and the primary care physician. For us, I mean, most of the people know that Miami market is mainly a HMO market, so most of the patients that we see go to the clinics or go to a primary physician, and then there's nobody to follow the patient right after when the patient is being discharged, to make sure that the patient doesn't go back to the hospital in case the patient need anything else, or in case the patient need any question or family question. So any needs that the patient have it in between, it wasn't covered. How do I know that? Because I've been dealing with that for almost 20 years. So I see the patient coming back to the ER for simple question, for medication, for any minor details that can be addressed in the outpatient setting. And that's why we decided to came with the idea, put together more effort in order to train the nurses better, to be able to identify what the patient need, how we can make the patient safe at home, feeling better, and avoiding the unnecessary hospitalization.
Yeah. I remember, when I first met you, back almost a year ago now, that it struck me as you being a different type of doctor, one that really understood the dynamics of the disease and was just not going to pass the buck. That you could really do whatever you needed to do as a primary care doctor and in the hospital as a hospitalist, to be able to really understand what's the next move. Not just, hey, listen, it's a little bit outside you were very comfortable with the whole gamut, of the disease and the disease management, where some doctors are very limited and they want to be very limited in their knowledge in the disease. What would you say that, knowing what you know now, I'd like to talk to you a little bit later about that review committee that you run now for the company for readmissions, but, what would you say sets us aside or apart from other from a home health agency? By the way, we have nothing to do with a home health agency. We actually are the ones that refer out to the home health agency, but when they talk about home health, they always think of home health agencies, those nursing agencies that go out there. So we're talking about home health, but we're not talking about the agency. We're talking about health at home, which is at the center, at the core of this company. What do you think sets us apart? You've talked to me a little bit about it sometimes.
Basically, this is one of the main focuses of the company that we have. I see that it's a big necessity on that point because this is what, according to whatever you said, I mean, the people see most of the as a home health agency when you go to a house, just review medication and don't do any intervention. Our company, the difference, like we are kind of new, we redefine the care at home. So not only
redefining care at home.
Yeah, not only taking care of the medication, not only taking care of the wound cares or antibiotics or whatever has to be prescribed for the patient, but also seeing the patient medical wise. That's why when we talk at the beginning, you decide that we need to retrain the nurses in order to be able to identify any potential complication or potential side effect of medication, potential problem that is going to be presented at some point. So it's before it used to be like what you said, it's a nurse, go to a house, see the patient, make sure everything's okay, but no intervention was done whatsoever beside the hospital instruction and the PCP that's going to be happening 1 week. Now we can do intervention 4 days after being discharged the patient. As far as you know, there's a lot of data saying that the patient, most of the readmission happen in the first week, 10 days after they discharge the patient.
Readmissions.
Yeah,
most of the famous 30-day readmissions.
Most of the readmission happen at the beginning, and when you see the committee that you already mentioned and what we are doing, our readmission rate is very minimum. And the reason why is because we'll be able to identify over there sooner than later what the patient may need to avoid going back to the hospital.
Yeah, I've seen some of the results coming out of that committee, and I sat in there at the very beginning just so that we made sure that we were in a good. I felt comfortable about the space that we were occupying and the outcomes of that committee. And one of the things that surprised me the most, Sergio, from that committee was that instead of medications being the primary reason why people were getting readmitted, nutrition came up more than medication. Can you talk to us a little bit about that?
Yeah, I mean, basically, we dealing with a very elderly population. I mean, chronically ill with multiple medical problems. So I mean, we see that. I mean, most of the nurses, healthcare professionals believe that if you do it's medication based, whatever they're going to be feeling, make the patient feeling better. We realize that we anticipate the proper hydration, proper food intake, all that details, helping the patient stay away of the hospital, avoiding infection like the urine infection, respiratory infection, even fracture because the patient feeling weak, get behind on the fluid and they fall and fracture hips. So there's a lot of new interventions that we are doing now. I believe that you should remember that when we start doing the committee of the readmission, we used to see 20 patients, 30 patients. Now, I mean, we see minimum amount of patients because we identify the patient there and we make an intervention right there to avoid that happen.
Well, it's incredible that you're saying that you're, because you would know because you do this on a regular basis that our patient base has gone up so much, but yet the number of patients that are being readmitted is so low. And I really thought, when I knew that when the government put the demonstration project out there, I said that we had to do this thing. I had been in the CMMI space before, and I said, we have to do this. But, I never thought that, never did it come to my mind that what we do or what we can do in the home and what we can find in the home as far as social determinants would be such a major player in the ability for that patient to be able to manage those diseases and be there in their home and live out their life in their home. I didn't understand that.
I mean, this is basically what medicine is all about. I mean, medicine, we are treating human people. So we don't treat it's not like a mathematical physics, like you can, 2 plus 2 is always 4. I mean, medicine, you go to a house, you see the patient is coming back to the hospital for urine infection, quite often. So you need to see how the patient hydration status is, how is the hygiene of the patient, the whole environment, that some people did not believe that matter. It matter. And we've been proving that we can make it better. I mean, the quality of life, the patients stay at home, and the whole environment, doing that minor change that we're able to identify. And also remember, it's really important for everybody to know. I mean, we're living in the society where you got the hospital pushing to the hospitalists to send the patient home quickly, because the diagnosis that the patient has is a DRG patient, or is a code that doesn't give you more than 3 days in the hospital. So you got also the insurance pushing on the other side. You got the physician in between. So you got all that situation.
Hard spot to be in.
And then you need to decide when the patient gonna go back. So whatever we are doing is extremely necessary to avoiding, the readmission and the patient going back to the hospital, improve the quality of life of the patient. And overall, I guess this is a kind of like a new idea what we are doing. But when we be able to show the result, there's going to be a lot of more people coming up on board.
Yeah, before you came, we sort of ran a survey on patients, 500 patients. We took 50 of them that had at least three of those 7 dramatic, conditions that we talked about. So very, very acute group of patients with at least 3 of those very serious conditions together. And we picked out 500. We did a survey on the 50 of them. And what we found is that once our services started, we were able to keep, not for a year, these patients should have been hospitalized with an 8 or 12%, that over a 2-year and 7-month period, 29 months, over that 29-month period, 34 patients never went back into the hospital. That was incredible for me. That was an incredible statistic for us. How do you see, that, how could that be so dramatic? You being so experienced in the hospital and not having seen the world that you're seeing now, but I think it was very easy for you to say, well, wait a second, this was the missing link. This was the mesh that was missing, How did you all of a sudden say, Mario, yes, I want to be more part of this. I want to help more people. I want to help people live in quality of life and age in place.
No, I mean, basically, this is. I remember when we meet for the first time about a year ago. What you said. I mean, you presented to me your idea, whatever you was been doing, and I just put in my mind the whole picture and said, this is probably what we need to make the patient quality of life better. And we've been doing that, we've been improving, because I see this is a missing part. Because again, what we said, the patient go home and you get a home health nurses that go to see the patient maybe in 2-3 days after being discharged without doing any change. Basically what the nurse does is make sure that the medication is properly and the patient follow whatever the doctor in the hospital said. But if something happened in that 2-3 days after discharge, nobody addressed that situation. You call the PCP, he's not available. You call, somebody. We see patient on Saturday. We see patient, and you open more, the care of the patient.
Really, 24/7.
24/7. That's how you make that change happen.
Yeah.
I mean, and again, at the beginning, a lot of people will say, no. We need to see data and numbers. If they try that, we do what we are doing on daily basis, they would see that number going up easily.
Yeah. I know. I'm convinced that they say that. Some very prominent people, now selected from the new administration, that when they made their opening speech or salvo, whether it was Kennedy or the NIH guy or voted as a secretary for NIH, or whether it's the new administrator, Dr. Oz, it's clear that they say that, in the Medicare space, 20% of the patients equal 66% of the cost. If you do the math at 4-point-something trillion, you're talking about almost $2 trillion and that is being spent there. And, I think that, what we're doing, if it was nationalized, it would be in the hundreds of billions of dollars in savings, let alone, the quality of life that they would have, with
it's like going back to the initial of the medicine. Remember at the beginning, I've been doing medicine for, almost I would say maybe like 30 years. But at the beginning, the medicine was like that. You got your doctor know everybody on the on the community, and then you need to talk to him. You talk to him at any time, at any days. He runs your house. He do whatever he does. So it's basically going back to the basics of the medicine. That at some point, with the new technologies and division and this and that, we're getting behind on that part.
Yeah. We re-siloed. We siloed the different aspects of medicine. And I know that home health agencies are great and they do a great service, but they don't have a doctor component to attach to them. And most of the time you find, since there's no compensation, now there is for the review of that care plan for the home health agency, but many times you find the nurses going in there doing their thing and not being able to communicate with the doctor on a real in real time. So we unlike them, our nurses are not there for home health. They're not there for a short while. They deteriorate. They're there for the ongoing. They get to know the patients on a really good basis. And then whenever they see something wrong, they can raise their hand, get somebody on the phone, get a doctor on telemedicine, and then we can make a determination. Hey, listen, this is a more serious thing. We need to spend more time with them. We need to get somebody else to evaluate, titrate medications in real time.
Yeah.
In real time, because the alternative is for them to end up in the hospital. And you were talking about it a little while ago, and it's nothing on the hospitals, because the hospitals are a great place and they're absolutely necessary, but they're not the best place to manage chronic diseases.
Yeah, no, I mean, and also I was on the phone with the patient from a company, maybe when I was getting to the office right now, and this is a classical example. This is a patient that go to the hospital with the high blood pressure and cardiovascular complaints. So we saw the patient, we made the change. Hospital situation is one place, home situation is totally different place. So we changed the medication, we adjusted the medication, the patient was watching 24 hours in the hospital, everything was okay, and then the patient's at home now, the blood pressure is 80 over 40 or over 60 or something like that. So we just right away review the medication, call the doses, because this is the classical example of what happened. So you got a home health there, whatever they do, they notice that, they see that there's a problem with the blood pressure, you need to call the PCP, get the PCP involved. The PCP will say, well, I'm not really sure because I need to see the hospital discharge paperwork. I'm not familiar with the patient. So we are familiar with the hospitalization of the patient, and we can do that change right there on time. And this patient, he continued taking the same medication that was prescribed in the hospital, that it wasn't run. It was properly for the hospital situation, but not for the home situation now. He can potentially falling, fracture one hip, and then going back to the hospital. This is exactly what we are talking about.
Over-medicating because there was no communication, and that's a siloed medical care that exists today that we've sort of broken through. And at this company, we watch them through the whole process. Whether they go to the hospital, nursing home, skilled rehab, whatever they're at, we're watching them, trying to get as much data as we can back so we can make sure we make the right decision for them.
We see a lot of patients that go for elective surgery or for surgery for gallbladder, appendix, prostate, whatever. Most of you got physicians listen to what we are talking. Most of these patients ending going home the next day, or some of them going home on the same day of the surgery, because this is a same day surgery, and they haven't been moving the bowel properly. So we see patients like that when you go to the house in 1 or 2 days, the patient is not been moving the bowel, it's not been making passing gas neither. So in this patient, it was advised to start eating right away, and then you're gonna go back to the hospital again.
Impacted
with
maybe
vomiting, abdominal pain, distension. And all what it takes is a minor intervention. Get in there, told the patient, don't take that. You take these laxatives. Don't start eating a full diet until you move the bowel. You do this and that, and that's you avoid it.
I'm smiling, but I'm not smiling because it's funny. I'm smiling because it's so easy, but yet it doesn't get done. Patient. Post-surgically, you're waiting for the patient to pass gas. They don't pass gas, or they do pass gas, and it's late in the afternoon. They discharge them from the day surgery, or they discharge them from the hospital without the patient actually having been able to go to the bathroom, essentially. In essence, if you just took care and you put them on Miralax or something like Miralax, it would resolve that problem. But if you don't do that, this is not a medical condition. It becomes a medical condition because the patient is eating and not going to the bathroom. 3 days later, now they're impacted. Now they start that stuff backing up, and and they become septic.
Yeah, but this is what happened. This is the change that we see that happening now. So let's see that hip replacement and knee replacement process surgery is like a same-day procedure. So technically, the patient should be getting to the hospital early morning, have the surgery done, and then go home. So go home and strong pain medication, narcotics that give you nausea, that give you dizziness, that give you constipation,
back you up.
and then before, I mean, years ago, this patient stayed in the hospital for maybe 1 or 2 days, getting better, or that, monitor the side effect of the medication, be able to move the bowel, be able to. Now you need to go home on the same day or the day after, early morning, because it's only same day. So in this patient, if we don't got anybody at home, be able to do intervention, not only see what they're taking or see what they're doing. It's not see, it's also see and do. You need to see and you need to do something about that. Yeah. Most of them, some of them, going back to the hospital. Yeah. If we can avoid it, I mean, if you get 100 patients that in that situation, you're avoiding 30, 20, 40 admission, that would make a big difference, big impact in the overall care.
Yeah, the overall care and the overall care, payer cost. Yeah, so yes, it's a win-win for the payers. It's a win-win for the patient. It's a win-win for the doctor. But wow, 30 patients being readmitted, and we saw it early. When we started doing this readmission reduction program back in 23, we started doing, and we have the data back that goes back there, and we talked about it the early part of the program. We spoke about it. Again, I saw something that was really incredible, and that was how much you could actually curve the readmission just by going to the patient's home and getting to see where they're at, what their capabilities are, what questions they had, because some of them go back just because they're not clear. And like you said a little while ago, some of them don't understand, do I take the medication that I got from the hospital and the one that I have at home, which is complicates. Now you got another situation on your hand. So it was very, very easy, very rewarding to us to know that we could do something simple as that. Obviously today, we get into very granular, very specific areas of medicine and to see how we can, together with you, research and find solutions that will, get our patients back home, faster, or not get them over to the hospital.
Yeah, and medicine is like that. It's always moving forward, but you cannot move forward forgetting what you left behind. So always start in the beginning. You'll be able to cover the beginning and move forward. That will be the ideal situation. That's basically what we are doing. We try to redefine the care at home when the patient is being discharged, when the patient is being transferred from the hospital to any type of facility. And also really important that we see not a lot of patients, but we see some of them. I mean, how often do we see patients that it doesn't get better? It doesn't get better. Going back to the hospital, we identify the situation is not getting better, well, because that may be the end of the problem. The patient may be in terminal condition, terminal cardiovascular condition, terminal situation that is not going to get any better. Yeah. This patient is being improved in data that causing a lot to the whole system. When we see to the patient, we explain the whole situation. We go from different point of view. They be able to stay longer at home, get the proper care.
Palliative.
That type of palliative care.
Yeah, palliative care. Yeah, it's been great talking to you again, Cesar. Again, for you at home, wherever you're at, wherever you're watching us or hearing us, it's an incredible thing. Somebody, or you have someone that's very dear to you that could use our services. It's a completely different way of looking at medicine. Not siloed, a 360 view. Not only do we watch you at home, but we watch you when you go to the hospital, or we watch you when you're at the nursing home to make sure that we have all the appropriate data. But I think that we educate you also to be a better informed patient about what you can expect or what you should expect from the outcomes. And I think that we call our care coordinators advocates, and I strongly believe in that. So we're going to leave you from our Miramar office. Thank you again so much, Dr. Rodriguez. Well, we'll leave you from our Miramar office. Again, remember, somebody or somebody that's dear to you can use us. Call us at 877-212-2267. Again, that number is 877-212-CCMS or 877 again, 212-2267. Call us. Thank you so much.